All right, welcome back to another med-minded video. Today we have more empiric antibiotic therapy by medication. This is part 2, and this features fluoroquinolones, tetracyclines, macrolides, folate antagonists, lincosamides, nitrofurans, and fosfomycin, and glycopeptides. So first up are the fluoroquinolones, the first of those being the respiratory fluoroquinolones, which include levofloxacin, moxifloxacin, and gemifloxacin. In terms of important coverage, they cover for enteral GNRs, atypical organisms, Haemophilus influenzae, strep pneumo, MSSA, and then levaquin covers Pseudomonas aeruginosa, and then moxifloxacin covers anaerobes. So it's important to remember those two in particular. In terms of important use cases, these are useful for community-acquired pneumonia. Levaquin is useful for urinary tract infections, gram-negative rod-related sepsis, and then moxifloxacin can be used as monotherapy in certain intra-abdominal infections because it covers anaerobes. So in terms of important facts, just to reiterate, levofloxacin covers Pseudomonas, moxi covers anaerobes, and then these are the respiratory fluoroquinolones because they cover for strep pneumoniae, which is unlike ciprofloxacin. So that's why they're the respiratory fluoroquinolones, because strep pneumo causes pneumonia, community-acquired pneumonia. So again, Cipro lacks strep pneumo coverage, so it is not a respiratory fluoroquinolone. However, in terms of important coverage, you still retain enteral GNRs, atypical organisms, Haemophilus influenzae, and then you also retain pseudomonal coverage, so that's excellent. In terms of important use cases, it's useful for urinary tract infections, gram-negative rod-related sepsis, intra-abdominal infections. You might want to combine that with Flagyl if you're using it for that indication, though, and then pseudomonal infections. So some facts about Cipro. Resistance is creeping up. So in terms of urinary tract infection treatment, pyelonephritis specifically, if your fluoroquinolone resistance rate is greater than 20% in your particular area, generally they recommend against fluoroquinolone use, and then they would instead recommend third-generation cephalosporins. So yes, resistance is on the way up. And then side effects of all the fluoroquinolones include tendon rupture, masking, hypoglycemia, and QT prolongation. And then fluoroquinolones are generally not used in pediatrics, and they're not really safe in pregnancy, so just something to keep in mind. Next up, tetracyclines. This includes doxycycline, which I see more than minocycline, which I see more than regular tetracycline. And then in terms of important coverage, these are quite an interesting class of medication. They cover atypicals, spirochetes, plasmodium, strep, and staph. So in terms of important use cases, they're used for community-acquired pneumonia, Lyme disease, skin and soft tissue infections, sexually transmitted infections, and malaria. So some fun facts about tetracyclines. They provide excellent MRSA coverage for outpatient treatment. So if you have somebody with some sort of purulent cellulitis or something with an abscess, you're going to send them home and you're worried about MRSA. Doxy has almost equivalent MRSA coverage to Bactrim, which is greater than 90% of MRSA strains being covered. So it's very excellent at covering MRSA. And then in terms of side effects, you see photosensitivity, so they're sensitive to the sun. They could get easy sunburn. Make sure you tell your patients to wear sunblock. GI upset, so take it with food. And esophageal irritation. So if you have a young child that is taking this for Lyme, you might, kind of think in the next point, oh, it discolors developing teeth. So there's a light contraindication to children under 8 years old, but it is still preferred for Lyme in some instances. So if you're going to give it to children and say crush up a tablet and put it in an applesauce or something, you're going to want to tell the parent or responsible guardian to have the child drink a lot of water after they eat the applesauce with doxy in it because it'll cause esophageal irritation. Next up, macrolides. This includes azithromycin, erythromycin, and clarithromycin. In terms of important coverage, they cover atypicals, strep pneumo, strep pyogenes, Haemophilus influenzae, Moraxella catarrhalis, H. pylori, and Mycobacterium avium. In terms of important use cases, they're used for various respiratory infections, atypical infections from mycobacteria, some infectious diarrheas, and then H. pylori, which is mainly clarithromycin focused. In terms of fun facts, they all cause QT prolongation and GI upset. They're all CYP inhibitors except for azithromycin, and then erythromycin is mainly seen as a pro-motility agent in gastroparesis. Rarely do we see this as like an IV injection or PO for something that's like systemically infectious. If you see an erythromycin suspension taken orally, it is usually used as a pro-motility agent. It's not actually used for any sort of systemic infection. Next up are the folate antagonists, which is mainly Bactrim, sulfamethoxazole with trimethoprim, which I tend to see a lot more than dapsone or pyrimethamine. An important bacterial coverage, it's staph, including MRSA. It's about equivalent to doxy, much greater than clindamycin. Stenotrophomonas multifida, Listeria, Haemophilus influenza, PJP, so that's Pneumocystis jirovecii, Enterogenars, Strep, Salmonella, and Shigella. So in terms of important use cases, you can use it for UTI, skin and soft tissue infections, Listeria infections, Pneumocystis jirovecii pneumonia, and occasional intra-abdominal infections, opportunistic infections, and then pyrimethamine can also be used for toxoplasma. So some important facts to know. Sulfamethoxazole with trimethoprim is pretty much always in a 5-to-1 ratio. So the double-strength tablets are 800 to 160, single strength is 400 to 80. And then another important fact to know, Bactrim interacts with warfarin, so avoid it if possible, otherwise it will warrant a dose reduction in warfarin. And then these agents typically and frequently cause rash, could escalate to Stevens-Johnson syndrome or toxic epidermal necrolysis, so watch out for that. They may also cause bone marrow suppression or transient increases in LFTs. Generally, these are side effects associated with Bactrim just because you don't really see dapsone or pyrimethamine unless you're working in some sort of specialty clinic that deals with these all the time, which I do not happen to be. Next up is lincosamides. This is clindamycin. So in terms of important coverage, it includes MRSA, strep, chlamydia, PJP, anaerobes, which gram-positive anaerobes are much better with clindamycin than gram-negative anaerobes, and then chlamydia trachomatis. So important use cases for clindamycin, periodontal infections, that's a big one we see in the ER, some sort of tooth abscess. And then skin and soft tissue infections, bacterial vaginosis, malaria, Pneumocystis jirovecii pneumonia. It can be used topically for acne or an add-on for necrotizing fasciitis. So in terms of skin and soft tissue infections, particularly with MRSA, at least in my area, Doxy and Bactrim cover like 93% of strains of MRSA. Clinda only covers somewhere around like 75%. So just something to keep in mind if you're going to choose Clinda. It may not be as effective as Doxy or Bactrim, but then again, there are downfalls with every medication, so it's important to keep it in mind. And then some other facts about clindamycin. It has 100% oral bioavailability, and you may notice that the oral doses are usually around 300 milligrams at a time, sometimes 450 at the max. But those are all limited by GI tolerance. So you might see an IV dose of 900 milligrams, but the oral dose is only 300 milligrams. That's because you will be pooping your brains out no matter what, and you won't even get the drug at that point. It's just, they are very limited by GI tolerance. This has been studied over and over again. Just take the package insert for what it's worth. So another fact about clindamycin, it carries a higher risk of C. diff than other antibiotics and a high incidence of regular diarrhea as a side effect too. Whether you want to call it Clostridium difficile or Clostridioides, up to you. I am stuck on Clostridium, so here we are. And then next fact, it is added on for necrotizing fasciitis due to protein synthesis inhibition. It has, quote unquote, an antitoxin effect. And then also, you want to remember the D test with erythromycin. So if bacteria are resistant to erythromycin but susceptible to clindamycin, so it makes you think that you can use clindamycin, there are bacteria that will be able to pass on the resistance that is carried with erythromycin and make the same bacteria resistant to clindamycin. So the way that you could rule this out is called doing a D test. So they will have inducible resistance to clindamycin. So forget all of that immediately and just know that D test equals Clinda plus erythromycin. Just associate them together forever, and you will pass any question about clindamycin and erythromycin use together, okay? So just remember the D test. So on to nitrofurans and phosphomycins. These includes nitrofurantoin or macrolide and phosphomycin, which is monurol. In terms of important coverage, they cover for E. coli, staph species, Klebsiella proteus, Enterococcus, and then phosphomycin also covers for Pseudomonas and Serratia, which is excellent. And then for important use cases, these are almost strictly used for UTIs. I literally cannot think of another indication for these medications. Unless you're living in like Canada and you have IV phosphomycin, good for you. I'm incredibly jealous. And then in terms of important facts, They work differently, but they're grouped together, but they alter and inhibit bacterial proteins and enzymes in sort of similar ways. It's really complicated, but they do always get grouped together. They're highly efficient in the lower urinary tract. They're literally useless everywhere else, so only use them for cystitis, UTIs. So in terms of renal dysfunction with macrobid, you don't want to use it. The recommendation used to be an EGFR less than 60 mLs per minute. You wouldn't want to use macrobid, but now they're going down as far as 30 mLs per minute, just because when you have a lower EGFR than that, you're not accumulating enough drug in the bladder to actually kill the bacteria. And that's how macrobid works. So that's really important. And then next fact, fosfomycin, it's a single dose treatment. So usually the recommended dose is 3 grams, which comes in an oral packet for dissolution. So you dissolve it in 6 to 8 ounces of water, you stir it up, you have the patient drink it, and boom, they're cured after, several days. But they don't have to take another dose. Some studies have recommended repeat dosing for, multi-drug resistant organisms. That's outside of my wheelhouse. It is a single dose treatment for all intents and purposes that you will probably encounter. And then the most common side effect with these medications is nausea and vomiting. So just take them with food, or if the patient says, yeah, I have an allergy to macrobid, it makes me nauseous, just tell them to take it with food. Just ask them to try. All right. Next up, glycopeptides. The first being vancomycin. So vanco works by binding to the terminal D-ala-D-alanine chain on the peptidoglycan of the cell wall. So peptidoglycans come together to make up the cell wall. And by binding to the terminal end, it stops elongation of the cell wall. So it leaves partially constructed or completely unconstructed cell walls, and then your immune system can take care of the rest. So in terms of important coverage, it covers for MSSA, MRSA, C. diff, strep, and Enterococcus faecalis, but not so much Enterococcus faecium. All right. So in terms of important use cases, it's used orally for C. diff or IV for MRSA infections like pneumonia, skin and soft tissue infections, and sepsis. So some facts about vanco. The oral formulation is not systemically absorbed very well at all, so IV is not effective for C. diff. Oral is not effective for systemic infections or infections outside of the GI tract. It can also cause an histaminergic infusion reaction called red man syndrome. It is not a true allergy. It responds well to Benadryl. All you have to do is slow down the infusion time. Most institutions I've been at will just say cut the infusion rate in half. So if you see someone lighting up red on a vanco infusion, don't come running at them with the epi and steroids. Just come running at them with the Benadryl unless their throat is swelling. So it's very responsive to Benadryl and antihistamines. So something to keep in mind. So vanco is also renally dosed, and it needs monitored based on trough. That's the old way. The new way is monitoring by AUC, so area under the curve. My institution still does trough monitoring, which I love because I don't have to put too much thought into it. As long as the trough's between 15 and 20, great, we're golden. And then it's also slower at killing methicillin susceptible Staph aureus than most beta lactams. Just think about how it works. It inhibits cell wall growth on either partially grown or unformed cell walls on the bacteria. And then the immune system comes in to kill the rest. It just prevents cell wall growth. So if you get something that's actually more effective in penetrating the cell wall, like the beta lactams, you're going to kill the bacteria much faster and clear that infection much faster. Next up is telavancin. It has the exact same mechanism of action as vancomycin. It does have the exact same coverage as vancomycin, but they have boosted the MRSA coverage to exceed what vancomycin already was. So they essentially engineered a new vancomycin that can hit infections much harder, even some that would be more resistant to vancomycin. So it's a modified vanco molecule, and it adds a lipophilic side chain to disrupt the membrane potential, and that alters cell permeability. So if you alter permeability, your immune system can get in there and start killing bacteria much better. So it expands on the MRSA coverage of vanco. Benefits are not really weighed. In terms of unique side effects, it adds taste disturbances, which are metallic, and telavancin is also notable for foamy urine. So just keep that in mind. And then Telavance is also contraindicated in pregnancy. It is a black box warning for contraindication in pregnancy, so keep that in mind due to fetal abnormalities. And then just like Vanco, it also requires a renal dose adjustment. All right, well, that is it for part 2 of ID by drug. I want to thank you a lot for watching. If you have any questions or comments, please check out that email address, send me an email, or comment questions and feedback below. I've been Robert Laska with MedMinded Consulting. Thank you again for watching, and we'll see you in the next video.